next slide seminar is on coagulation studies, one approach by Dr. Ruchi and Dr. Dinesh sir. So with this, we'll start our today's session. Over to you, sir.
Thank you so much, Lopa. Let me just try and share my presentation.
Lopa, you'll have to stop sharing. Huh.
Yes, ma'am. Yes, ma'am.
Is everybody able to see this?
Yes.
Yes, sir.
Fantastic.
Yes.
It's a pleasure to be here today, and many thanks to Dr. Borges and Dr. Gujral for kindly inviting me to speak. What I'm going to try and do today in the next hour or so is to take you through how to deal with a bone marrow biopsy. And I think one of the most difficult things that we actually find is we need to understand what is normal before we try to go into abnormal. So I'll try and take you through what the normal bone marrow biopsy looks like, what we need to look for, and how we need to deal with it. This talk is interspersed with 4 cases, and there are a couple of questions, so we can talk our way through those. So where did this word bone marrow trephine come from? It came from the word trepanning, which was basically an ancient Egyptian technique of removing a small bung of a bone. You can see the skull over here, and you can see that they've removed a small circle of bone. And the Egyptians used to do this to try and treat increased intracranial tension. And that's where the word trephine comes from, i.e. to remove a core or a cylinder of bone to try and evaluate diseases of the bone marrow. When people couldn't get bone marrow biopsies, they also used to use clot preparation. So you got aspirate, you clotted it, and you then cut sections of it. The most common sites for obtaining bone marrow biopsies are the posterior superior iliac spine. So when you can't get it from there, you try and get it from the anterior superior iliac spine, breast. Rarely in children, you can use the tibia. We used to use sternal biopsies previously, but we've had a couple of cardiac tamponades, so nobody uses sternal biopsies as a means of obtaining diagnostic bone marrow anymore. In the rare situations where you might be forced into something like this, you have to ensure that your needle guard is set at 1 centimeter. So the needle cannot go more than 1 centimeter into the sternum. And very, very rarely, you might get a sample from the vertebra when there are no other accessible sites. We've moved a long way in terms of what needles we use to acquire bone marrow biopsies. So right in the center over there is, and I'm just going to try and annotate, is our old Jamshidi needle, which is this one over here. And this is what we used to use in the days of old, and it had to be sterilized after every use. We have now moved to things like this, which are disposable biopsies. They come with a trocar and a needle. And you can see that you get very, very nice cores of bone marrow designed to cut through the cortical and subcortical bone to give you intact cores of bone marrow. Okay, I think perhaps I need to stop annotating before I can move ahead.
Yes, sir.
Now, does size of bone marrow, the length of the bone marrow biopsy matter? I would say it does really matter. The standard size that we would like for diagnostic assessment is about 2 to 3 centimeters. But this is not usually the case in day-to-day practice. So you get all sorts of biopsies. You get stuff like these, which are really, really short, tiny cores. You get these, which is by and large what you would get in day-to-day practice, which is something between 1.5 and 2 centimeters in size. And then, of course, you've got some spectacular colleagues who can do really, really good bone marrow biopsies, like the last 2 pictures at the bottom of the screen, which are in the region of about 3 centimeters. And length of the biopsy does matter, because just imagine that if this biopsy were to have stopped midway, you would have missed this lymphomatous infiltration in the bone marrow. So all sorts of focal diseases would be missed if you did not examine a bone marrow. try to get a biopsy which is at least 2 centimeters in length. By and large, you tend not to miss pathology if you've got a biopsy of that length. Now, how do we deal with bone marrow biopsy? So the first thing would be to fix it, and most of us would use neutral buffer formalin. It's important to remember that bone marrow biopsies should not be overfixed because it interferes with all sorts of things subsequently, antigen retrieval for immunohistochemistry, nucleic acid preservation for molecular testing. So anything less than 24 hours is good. There are lots of other solutions that people used to use in the past, including Bowens, B5, Schaefer's, and all sorts of commercial fixatives. It depends on where you work, but Neutral is easily available and does a fantastic job. Following fixation, we need to decalcify the marrow before we can cut it. So there are a couple of methods for decalcification. One is you use acids like formic acid or nitric acid to decalcify. The advantage of acids are that they decalcify very, very fast. But the problem is they make the biopsy brittle, and nucleic acid preservation is really, really poor. So you can't do any answer testing on those biopsies. So by and large, we've stopped using acids as decalcifiers. Currently, the international standard is to use a chelating agent, which gradually substitutes calcium from within the biopsy. And the standard solution that we would use would be an EDTA solution. The disadvantage of using EDTA is that it takes slightly longer, so it requires at least 48 hours for the biopsy to be in the solution before it's decalcified. But if you've got access to the bone station, which is the automated way of decalcifying, you can set up protocols to reduce the EDTA decalcification time to 10 hours. So effectively, if you've got a biopsy done in the morning and it's adequately fixed, you could put it into EDTA overnight and process it. There are a couple of combined fixatives and decalcifying protocols, like the AZF protocol, which was popularized by Professor Naresh. They work well. It works in about 18 hours, and you get decent morphology and immunohistochemistry. The disadvantage with these, again, is that nucleic acid preservation is not very, very good. So following fixation, we have to embed, following fixation, decalcification, we process the biopsy. It's done by standard methods for all other tissue. And then we embed it. There are two would be to use paraffin, like for conventional tissue. If you were in a really specialist institute like in Germany, you might want to embed it in plastic to get really, really thin sections. But very, very few centers would now embed in plastic. So most of us use paraffin for embedding. Now, the most important thing when assessing bone marrow biopsies is the quality of sections that you get. And the frame that I get is, oh my God, it's such a difficult, organ to evaluate. There are so many cells, it's impossible to make out what is happening. But it's not really true. If you've got a decent section of the bone marrow, it becomes very, very easy to interpret. Now, the one thing that you've got to remember is that unlike every other organ in the body where we would try and cut sections which are about 3 microns in thickness, bone marrows need to be cut a little thinner. So somewhere between 1 and 2 microns works beautifully. You have to have a very, very good relationship with your laboratory technicians to get good bone marrow sections, and you have to help them to troubleshoot when you don't get good bone marrow sections. The things to remember is the block really needs to be cold, so make sure that it's soaked properly in ice. The microtome needs to be calibrated well and set properly. And the technical movement of moving the microtome wheel needs to be very, very smooth. Now, if you satisfy all of these criteria, the most important thing subsequently is to ensure that the biopsy, the section, is floated for a significant amount of time on the water bath to allow all the creases to disappear. And if you can do this, you'll get lovely sections which you will never have a problem in interpreting. Just to show you what happens with good sections and bad sections, So if you look at the top image on the left, that's a rather thick section, everything looks pink and blue and you can't make out much. But if you look at the corresponding section picture on the right, you can see that suddenly, once it's cut thinner, you can make out a lot more features like what's happening in the cytoplasm and so on and so forth. Similarly, if you look at the lower left picture, that's a really thick section of bone marrow. You can see a lot of nuclear overlapping. You can't make out anything. If you look at the thin section cut from the same biopsy in the same area, suddenly morphology becomes much, much easier to interpret. So once you've got your sections, the standard stain that we would use for evaluating bone marrow biopsies is the H&E stain. Previously, GIMSA was used as the standard mechanism of staining bone marrow biopsies, but we tend not to frequently now, and that is largely because we've got a whole host of immunohistochemistry available, which allows us to selectively mark the different cell lineages that are present in the bone marrow. So we've got markers for erythroid, myeloid, megakaryocytic, macrophages and monocytes, for stem cells, hematogones, lymphocytes, plasma cells, and mast cells. So whenever we've got a problem, we can do immunohistochemistry to try and determine what is happening in the bone marrow. Okay, let's move on to what does the normal bone marrow look like? So this is a composite image of what a conventional biopsy would look like. So right at one end, if you look at the top corner, and I'll just try and see if I can annotate again. Sorry, let me go back. One sec. Let me just try and annotate. Yeah. So right at this end, you've got blood clot, and immediately beneath that, you've got this pale pink area of dense collagen. That's the periosteal soft tissue. The next thing underneath that is your area of cortical bone, which is this area. You can see that the bone is really dense and it doesn't have much in the way of intertrabecular spaces beneath it. And then you've got an area of marrow, which starts from there. You can see that the trabeculae, the bone breaks up into trabeculae, and you start getting marrow spaces. And as you go deeper into the biopsy, like in these areas, you can see that the bone trabeculae become really thin and the marrow spaces increase in size. And this is where we actually look to try and find out diseases. Okay? So if I just click on this, hopefully that'll go. And I will have to get out of annotate. Yeah. So the first thing that we would do when we are trying to assess a bone marrow biopsy is evaluate cellularity. Now this is a really, really important assessment because it tells you many things. Cellularity of the bone marrow is proportional to the age. Now if you'll ask me what is the meaning of cellularity? Basically, cellularity is the ratio of fat cells to the amount of cell. And the very simple formula, the cellularity of the bone marrow is 100 minus the age of the patient. And this formula works very, very well for adult patients, tends not to work very well for children, and doesn't work at the extremes of age. So, for example, if you had somebody who is 40 years old, 100 minus 40 is equal to 60. So you would expect cellularity to be about 60%. As you cross 70, 75, cellularity tends to remain constant at about anywhere between 20 and 30%. And in children, again, when you've got somebody who's just been born, cellularity is 100%. It remains between 100 and 90% till they're in their 8 or 10 years. And then then the fat content gradually starts increasing. So by 20, you actually got 80% cellularity. The one very important thing to remember when you're trying to assess cellularity is please do not assess the immediate subcortical bone marrow. So basically, if I go back to this image where you've got your cortical bone, first 2 or 3 trabeculae beneath it, do not assess because that is largely contains fat. Once you've assessed cellularity, you are able to determine whether the marrow is normocellular to the age of the patient, whether it has more cellularity, which we call hypercellular, or it has less cellularity, which we call hypocellular. And these are really, really important conditions because they define disease processes. We won't go into that for the time being. The next thing to do is how do we evaluate the bone marrow? Now, like most other organ systems, the bone marrow is also organized and structured. It's not just a mass of cells which are there higgledy-piggledy. It has got a definite structure. So the first thing that you have to do is identify what to look for. So when we look at bone marrows, we try and look at what is happening between the intertrabecular space. So you've got one trabeculum on the left-hand side, and you've got another trabeculum on the right-hand side of this picture. You've got marrow in between, and that is known as an intertrabecular space. Within this intertrabecular space, you have got 2 major components. One is the cells, and the other is the fat. Now, how do we make sense out of this? So let's look at it this way. If you were going to split that intertrabecular space into half and divide that half into 3 distinct areas, you would see different cell lines areas. Simple. Just give me one sec. So you can see that there's bone over here, right? So this is trabecular bone, and this is where the trabecular bone ends and the marrow starts. So now I've divided this into the third, which is closest to the bone. And basically, if you look, this is where most of your cells are mononuclear, and these are immature myeloid cells. So you would expect your myeloid blasts, promyelocytes, and myelocytes to largely be present immediately adjacent to the bone. If you go to the next third, that is the middle third, you can see that the cells change. You're suddenly starting to get more blue cells over here, and they're variable in size and shape. And this is where you end up getting most of your erythroid series cells. Okay, so RBC production happens in this particular area. If you go to the inner third of the intertrabecular space, you can start seeing these large giant cells, which we call megakaryocytes. So they're largely present towards the center of the intertrabecular space. And the inner 2/3 of the intertrabecular space also contains your differentiating myeloid cells. So you expect to see metamyelocytes, band forms, and neutrophils towards the center of the intertrabecular space. If you remember this organization, it becomes very, very easy to look for different kinds of cells and see whether they are present where they're supposed to be, which is normal, or whether they're spilling into other compartments, which is abnormal. So let's move to case 1. And I've got a picture over here, and we've got a couple of questions. And maybe we'll start with the first question, which is describe what you're seeing. So maybe Dr. Aarti can tell us what it is that we are seeing in this photograph.
Yes, sir. So in this particular slide, I am able to see a section of bone marrow trephine biopsy with
Okay.
some fat spaces and some marrow elements in it.
Okay, you're seeing myeloid elements. Excellent. Okay.
Yes, sir.
yes,
Marrow
Cass.
elements.
Marrow elements. Excellent. Marrow elements. Yes.
So the cell which has that arrow mark, it's a large cell with foamy cytoplasm, and it has engulfed some of the erythroid series cells and I think there is a cell from myeloid series as well. So
Okay.
most,
So let's just so here you saw marrow elements. Are you able to tell us what particular kind of marrow elements you're preferentially seeing in this picture? Is there any kind of marrow
in
cell
this,
which predominates?
yes, so I am able to see erythroids precursors and few myeloid precursors as well, and along with
Fantastic.
eosinophil.
So this is what I wanted to come out of this picture. Effectively, what you're seeing between the top fat cell and this bottom fat cell is an intensity of blue nucleated cells. So the blue comes
Yes,
out very, very well.
yes,
And when you're seeing blue in the bone marrow, it can mean only one of two things. Either you're dealing with erythroid cells or erythroid colonies, or you're dealing with a lymphoid infiltrate. Those are the two things that produce blue color in the bone marrow. Okay. So I
yes,
think, Aarti, you've done brilliantly. Thank you so much. And you've also described what that large arrowed cell in the center is. Now, if I could ask Dr. Harini, what do you think that arrowed cell actually is? Are you able to give it a name?
It is a nerve cell. Actually, it is an erythroid island where we are having
Hmm.
nerve cell in the center surrounded by the erythroblasts.
Excellent. And do you know what that nerve cell actually is? What kind of cell is it?
So it's a macrophage, fully macrophage with
Ex-
stainable iron deposits in the cytoplasm.
Fantastic. So it's a macrophage, and you're able to identify some, I think, brown colored pigment. We can see that, where the
MSCT.
cell is slightly foamy, you can see that there is brown pigment in them. So wonderful. We've got what is known as an iron-laden macrophage, which is present at the center of that colony. Excellent. Perhaps I can move to Dr. Richa. Richa, what stains would you use if you wanted to highlight this particular cell? And colors would the iron within that macrophage come up with depending on the stain that you used? So can you tell me about iron stains? What stains do you
So
think you
Pearl
used?
stain
Excellent. And
and Pearl stain and Jimsa stain.
wonderful. What color does iron pick up on the pearl stain?
So blue color.
Blue color. And what's the usual background for the pearl stain?
Pardon, sir?
Do you know what color the background is in the pearl stain? So we know that iron picks up blue because of the Prussian blue reaction. But what is the color? No, not to worry. It's orange. So normally the counter stain for pearl stain is a pinky orange.
Red.
Okay. And if you're going to stain this section with Giemsa, what color do you think the iron would pick up there?
Olive green.
Excellent. So pick up olive green. So now you know how to identify an erythroid colony. You know what kinds of cells reside in an erythroid colony. You also know how to identify iron-laden macrophages and try and assess what stains can be used to assess iron within the marrow. So if I move to Dr. Brinda, to my last question, what factors must you consider when evaluating the contents of a bone marrow biopsy? So what information is essential before you start evaluating a bone marrow biopsy?
Sir, first one is the adequacy criteria. So we see the cellularity of the marrow is whether adequate or not.
Yep,
For that, the formula one is the 100 minus age,
yep.
and we in that we sees the precursor from the erythroid, myeloid series, and megakaryocyte, means the erythropoiesis, myelopoiesis, and poiesis and granulopoiesis we will see. Then the arrangement of the cells we will see, means the topography of the cell.
No, Brinda,
Then
what I'm
the
asking is before you start your histologic evaluation, what information is essential for you to try and evaluate a bone marrow biopsy? So remember, you are a clinician, you're a diagnostician, right?
Okay.
What information do you require, whichever colleague is referring a bone marrow biopsy to you, what information do you require them to provide you? Without which your
Sir,
interpretation is not going to be as good as it might be.
sir, the history of the patient,
Hmm.
then the uh, then the requirement specific indication for the bone marrow biopsy, uh, then physician's name,
Okay. You will be able to
patient's
interpret a bone marrow biopsy without the physician's name, right? That's not going to
yes,
make a difference on how you diagnose. Remember, you were saying something about cellularity. What is it that
yes.
you can't assess cellularity without?
Sir, we can see the length of the bone marrow
You mean the
biopsy
patient,
length.
right?
Yeah.
So yes. So if you're going to ask me that same question, I would say that one, yes, the bone marrow biopsy does need to be adequate. Two, I would certainly need the age of the patient because without the age of the patient, I don't know how to assess for cellularity, and it doesn't tell me whether there is something pathologic going on in the bone marrow. Two, I would really like to know the hematological profile of that patient. What are the patient's peripheral blood counts? Without that, again, trying to make sense of what is happening in the bone marrow is a little difficult. And three, yes, of course, we would like to know what the clinical history of the patient is. So we require these three pieces of information to be provided to us upfront if we are going to be doing a good job. Does that make sense?
Yes.
Great, fantastic. Let's move on. So let's talk a bit about erythroid series and how to identify them. So basically, erythroid cells are present in the form of small groups within the middle third of the intertrabecular space. And they're cohesive, they're variable in size, and they're very easily recognizable because they're blue in color. Because by and large, they're predominantly nucleus and have very, very little cytoplasm. As you have very correctly pointed out, each erythroid colony is associated with an iron-laden macrophage. And I'm not going to sit and try and teach you what the morphology of the different stages of erythropoiesis is. That is something that you learn beautifully when you're evaluating the aspirate. Let's look at the trifine morphology. Now, all of you have very correctly pointed out the presence of the nurse cell or the iron-laden macrophage in the center. So you can see that schematic over there. The macrophage has multiple functions. It nurtures the cells. It takes them through the differentiation stages of erythropoiesis. And it also provides them sustenance. So it acts as a reserve for iron, which is required for erythroid cytoplasm to form hemoglobin. Now, a good way of identifying erythroid cells is to look for the halos around the cells, and I've got higher power magnification of that. So if you look at the picture on the right-hand side, and you've got this arrow over here, so erythroid cells, by and large, have perfectly round, inky blue nuclei. Depending on their stage of maturation, they have variable amounts of cytoplasm, which tend to be basophilic, but they have this lovely halo around the nucleus. You can see very well over the left corner of the picture. Let me try and see if I can annotate again. One sec. Okay, if you look at this particular cell, you can see a very, very nice halo around the nucleus. So that's a good way of identifying erythropoiesis, and this is an artifact produced by fixation. Erythroid cells, you can identify the different stages if you want to. So, for example, the largest cell like this one is your proerythroblast, and they have a large nucleus, limited cytoplasm. The chromatin is very, very open, and you can see a couple of nucleoli. As they differentiate, they become smaller, So they become normoblastic like those things, then the normoblasts become late normoblasts, and then finally the nucleus is extruded out, and that's a reticulocyte nucleus floating around. Okay? So let's get rid of the annotation and move on. If you are having trouble identifying erythropoiesis, you can do immunohistochemistry. And there are multiple erythroid markers available in the market. The most commonly used one is glycophorin A or glycophorin C. You can see it highlights very well. The problem with the glycophorins is they identify not only the nucleated erythroid cells, but they also identify RBCs, which often confuses the picture when you're trying to determine the ME ratio or how much is actually erythroid proliferation and so on and so forth. And if you get hemorrhagic marrows, you get a lot of, false glycophorin staining. There are more selective markers available, like alpha hemoglobin, which stains the cytoplasm of erythroid cells, and that's very, very specific. Okay, let's move on to case 2 and concentrate on the left-hand picture. Okay, so perhaps Dr. Xenia, you'd like to try and respond to my question? Can you see that there are 2 short white arrows? Xenia, are you there?
Yes, sir, I'm there, sir.
Excellent. Can you try and describe the 2 cells that are highlighted by the short white arrows? I just want a description. What do you think? How would you describe those cells?
Sir, this is an H&E stain slide of bone marrow biopsy, and we are seeing cells in paratubercular region. So these are round cells with the cytoplasm, and the nuclei there is nuclear presence of nucleoli. So these might be myeloblasts, sir.
Okay, I would like to know how you jumped to that conclusion.
Sir, the location of the cells.
Very good.
And so there is a prominent 1 to 2 nucleoli inside the cell.
Okay.
And sir, the chromatin is a little vesicular like.
It's open. Very good. Okay, I think you're absolutely correct. Those are myeloblasts. And if I can, just for the benefit of the rest of the audience, try and explain why you've come to this correct conclusion. If you look a little lower down on that picture, you can see that there is a lymphocyte nucleus. Okay, the dark blue cell. You can see that the 2 arrowed cells are medium in size. They're much larger than the lymphocyte, right? They have negligible cytoplasm. You can't actually see the cytoplasm very, very well. They seem to be predominantly nucleus. The nucleus is round to ovoid. It's got very, very open chromatin. It's got pale chromatin. And it's got nuclei. And that is the definition of a myeloblast. So the same definition that you would use on aspirate, you would use on the trifine. So if you've got a nicely cut section, you can identify the myeloblasts if you want to. Very well done, Xenia.
Thank you.
Nitesh, can I ask you the next question? You've got a blue colored arrow. Could you just describe that cell?
Sir, this is the cell prepared from slide bone marrow biopsy, refined biopsy, and cell is single cell.
Nitesh, let me help you over here 1 second. I would like to know from you, what do you think the size of the cell is? Is it a small, medium, or large cell? I'd like a description of the cytoplasm, and then I would like a description of the nucleus.
Yeah, cell size larger than lymphocyte, and cytoplasm is scanty. and nucleus ovoid, and once clear visual nucleoli.
Okay, and do you think there's one nucleolus or are there multiple nucleoli?
A single nucleoli.
Excellent. There is just one nucleolus.
Yes, sir.
Could I just remind the audience that they should not be sending me requests to annotate? Okay, excellent. And Nitesh, can you tell me a little about the cytoplasm of the cell? Now, we've already had Xenia describing the myeloblast cytoplasm, right? Which we said was very, very significant. How
Yes, sir.
is the cytoplasm of this particular cell different?
Sir, cytoplasm is more than a myeloblast, and
does it look more
eosinophilic cytoplasm, sir.
Excellent. So I think Nitesh, you've done a wonderful job. So this is definitely a larger cell than the myeloblast. It's quite big.
Yes,
You can make out a distinct rim of cytoplasm around it, which is eosinophilic and denser. It's got a very, very large nucleus, and it's got a single prominent nucleolus. Nitesh, I know you've just started training. Can I ask, do you want to hazard a guess as to what kind of cell this might be? If you don't know, it's fine.
Yeah, sir. Don't know, sir.
So this is a classical description for a promyelocyte. Okay, this is what promyelocytes look like. Wonderful. You both done very, very well. Now let's move to the picture on the right. And perhaps we can go back to Dr. Aarti for this question. I've got one white colored arrow, which is situated somewhere near the B.
Yes, sir.
Would you like to describe that cell for us?
So it is somewhat an intermediate sized cell with
Fantastic.
pale eosinophilic cytoplasm, and nucleus is in band shape. So it is a band form.
Wonderful. So you've got a medium-sized cell. It's got some kind of cytoplasm around it, and it's got a U-shaped or kidney-shaped nucleus, and that's a very, very good description for either a band form or a metamyelocyte. Very well done. And Dr. Harini, if I could move to you for my next question. I've got two cells arrowed with green-colored arrows. Do you want to describe them and tell us what you think they are?
So those two cells are mature neutrophils.
The neutrophils, very good. Why do you think the neutrophils?
It has three lobes, nuclear lobes.
Very good.
And,
So basically,
granules are not toxin.
okay. Very good. So we've got a segmented cell which has got cytoplasmic granule, which we know is a neutrophil. So effectively what we've done across these two pictures is we've gone through most of myeloid maturation. We've gone from the immature cells, which are located near the bony trabeculae, and which are by and large mononuclear, to our differentiated myeloid cells, which are located more towards the center of the intertrabecular space. And rather than having mononuclear nuclei, they start having segmented nuclei. And effectively, if you understand that, you've covered most of myeloid maturation. Very well done. So let's talk a little about myelopoiesis. And why can I not move the slide? Excellent. So as we all know, myelopoiesis is preferentially seen along the endosteal surface. It's also seen around small arteries because as they go through the bone marrow, they carry an investment of myeloid cells around them. And you can see this very nicely in this picture. So at the bottom, you've got bone, and immediately adjacent to it and going into the marrow, you can see a lot of mononuclear cells which are so really characteristic feature of myelopoiesis. And on the right-hand side, I've shown you the pictures of what different stages of myeloid cells look like. Again, the same definitions that you would use for an aspirate, you would use in the trephine. So just for the audience's benefit, we'll just quickly go through the different kinds of cells. So what I'm arrowed are myeloid blasts, limited cytoplasm, medium-sized cells, large nucleus, open chromatin, and multiple punched out nucleoli. And then you've got the promyelocytes, which are the thicker arrows, much larger than the myeloblasts, abundant eosinophilic cytoplasm, which looks granular, large nucleus, single prominent nucleolus. And this is just a higher power magnification to show you promyelocytes when they proliferate. You can see how distinct the granulated cytoplasm is. And then, of course, you have myelocytes, which are slightly smaller. So they are actually medium-sized cells. And you can see that the nucleus is getting a little smaller. And very, very importantly, see the nucleus is getting denser. It no longer has the open chromatin. The chromatin is becoming coarser, which is why they are appearing more blue and purple. This is what immunohistochemistry for myelopoiesis would look like. And the standard stain that we would use is myeloperoxidase. And you can see that it's a cytoplasmic stain. And you can see that most of myelopoiesis is present around the trabeculae. That is the top left picture. Okay. And the bottom left, the whole of the left picture shows you two bony trabeculae with myelopoiesis preferentially located around the trabeculum. If you look at the pictures on the right-hand side, the top shows you myelopoiesis around blood vessels. Okay, you can see that there are negatively staining blood vessels in the center, and there's a cuff of myeloid cells around these vessels as they course through the intertrabecular space. Now, if we move to differentiated myeloid cells, which are your metamyelocyte, band form, and neutrophil, so that's your metamyelocyte. Intermediate size cell, large U-shaped nucleus, and then you've got your segmented forms, which are neutrophils. And the preferential stain for identifying differentiated myelopoiesis is CD15. So if you use a combination of MPO and CD15, you can identify both the immature myeloid cells, which are stained with MPO, and the differentiated CD15. Now, please misunderstand what I'm saying over here. Both stains identify all stages of myeloid differentiation. It's just that the MPO picks up the immature forms strongly, while CD15 highlights the differentiated forms strongly. Okay? So it helps when you're trying to make assessments. Other myeloid cells within the bone marrow include eosinophil and basophil precursors. We all know that eosinophils are very easily identifiable because they've got prominent eosinophilic granules, and by and large, they have a bilobe nucleus. So very easy to differentiate from promyelocytes. Basophils are very, very difficult to identify on bone marrow histology, largely because they are smaller in size, and two, more importantly, because their granules are soluble in water, so they don't stain with hematoxin and eosin. If you really wanted to identify basophils, you would need to do immunohistochemistry. So you do have specific basophil markers like the ones I mentioned below. And CD123 also highlights basophils. The next thing that we do when we're trying to assess the bone marrow is try and determine what the myeloid erythroid ratio is. Okay? And this is very, very helpful in trying to differentiate between various disease processes. So in the normal adult, the ME ratio is 3 or 4:1. So for every erythroid cell, you have about 4 myeloid cells. So myelopoiesis predominates. Okay? Now you have to remember that the ratio reverses in children. So immediately after birth, it is erythropoiesis that is predominant. And then gradually, as children become adults, myelopoiesis takes over. Okay, let's move on to case 3. And And perhaps we can, Dr. Richa would like to start. Richa, what is the cell highlighted by the long white arrow which is present in the center of the picture between the two fat cells? Do you want to describe it and tell us what you think it is?
So this is a large cell with abundant eosinophilic cytoplasm,
Okay.
and the nucleus has many lobations, a multi-lobated nucleus.
Okay.
So this is megakaryocyte.
Fantastic. Now, can I just ask you to elaborate on the large? Is it as large as the promyelocyte, or do you think it's larger?
It's larger.
It's significantly larger. It's the largest cell in the bone marrow, right? Wonderful. If you, Dr. Brinda, what immunohistochemistry would identify this particular cell? Can you think of any immunohistochemical test that would identify this cell specifically?
So CD61, CD41, and for CD42B.
Excellent. So we do have, in the event that you have difficulty in identifying megakaryocytes, we do have specific stains which highlight the megakaryocytes. Very good. Those answers were all correct. And perhaps if I move to Dr. Xenia. Xenia, in the bottom third of the picture, there is a short white arrow. What do you think is happening over there? Xenia, are you there? I think there was something flashing. No? I think perhaps she's not there. Aarti, would you like to respond to this question?
Sir, I think there is hypolobation of nucleus,
Okay.
but I'm
I
not
want you
sure.
to step back a little. Forget about how we're going to describe that cell. I want you to tell me about the cell and what's happening.
Is
Aarti?
there budding of I'm not clear of the picture.
Mufi, there
Yep.
is a request that you use a laser pointer. Do you know how to do it? Just right
Hmm.
click with your mouse.
Okay.
Okay, and you get a menu and then it says pointer. Can you see? Pointer
Yep.
options. Okay. And then it
Yep.
says laser
Fantastic.
if you go down. Yeah. All right.
Can I?
Oh, sorry.
Thanks.
Sorry to.
No, not at all. Thank you, ma'am. Okay. Aarti, do you want to describe what we're seeing, or can I ask one of your colleagues to try? We're
Sir, I'm
talking
not
about
sure.
this particular cell. What's
Yes, sir.
happening around it?
Surrounding the platelet, I could see few erythroid, late erythroblasts have been surrounding the megakaryocyte
Very good. So we've got
on the
all
top.
these blue cells adjacent to it, which are erythroid. Very good. We know that this is a megakaryocyte. And
Yes,
on the left-hand side where my arrow is, we've got two fat cells. So are you happy
fat
with that?
cells.
Wonderful.
Yes, sir.
To the right of that cell, what do you think this particular space is?
Is it a sinusoid? Sinusoid.
Very good. It's different from all the fat cells, right? It's
Yes.
elongated. It seems to have cells floating in it. And
Yes.
yes, it's a vascular space. It's a bone marrow sinusoid. Yeah?
Yes,
Very
sir.
good. What do you think the megakaryocyte is doing in relation to the sinusoid?
It is letting out the platelets.
Very, very good. So effectively, you've got a very, very rare image of how platelets actually enter the circulation. So the reason why megakaryocytes are located preferentially within the center of the intertrabecular space is because that's where the greatest concentration of sinusoids is.
Yes.
And basically, we know that platelets are fragments of megakaryocyte cytoplasm.
Yes.
So what megakaryocytes do is they migrate through the bone marrow, try and find the sinusoid, and then oppose themselves to the wall of the sinusoid. Okay? And then once they are adjacent to the sinusoid, they try and push bits of the cytoplasm through the intercellular junctions between the endothelial cells of the sinusoid. Once those get through, what happens is because of the blood pressure, the blood flowing through, it breaks off those fragments of megakaryocyte cytoplasm, and that's how you get platelets and blood. So this is a wonderful example explaining the physiology of platelet production and how they actually enter blood. So that was a great description. Thank you. Okay, let's talk a bit about megakaryocytes. We already know where they're located. You all have described that it's the largest cell and it's got a lobated nuclei. Very nicely seen over here. So lots of lobes to the nucleus. We've already discussed how platelets get in. And eventually what happens is once all of the cytoplasm has disappeared into the blood as platelets, all you're left with is a nucleus. And you can see the nuclei here. Can you see this? There's a nice big nucleus there. There's another one there. And these are called naked nuclei. So this is all that is left of the megakaryocyte after it releases platelets into the blood. And eventually these nuclei degenerate and are mopped up by the macrophage in the bone marrow. Now, megakaryocytes, because they're so large, you see them in different shapes and sizes, and I'll try and explain why that happens. But you get an entire spectrum of what megakaryocytes look like within the bone marrow. So trying to determine what a dysplastic megakaryocyte is very, very different. Now, that's a topic for an entire separate talk, so we're not going to try and address that today. But all I want you to take away is that megakaryocytes can look very, very variable in the bone marrow, even normal megakaryocytes. The picture on the left-hand side shows you a very, very good naked nucleus. This is what megakaryocytes look like after they've been spent. Now, I'm going to help you with one aspect. Why do normal megakaryocytes look so different? And the reason is very, very simple. It's a very, very large cell. It's about 180 microns in width. Think of the megakaryocyte as a football. Okay? It's a round three-dimensional structure. So if the plane of your section passes through there, it's going to look like that. It's going to look very, very small and it's going to look monolobate because that's where you cut the lobe of the nucleus. If you go a little deeper, that's what it's going to look like. It's going to look polynuclear, okay, because you're cutting the lobes at different places. If you go deeper, it looks like this. If you go there, it looks like that. And if you hit the edge of the cytoplasm, all you're going to see is cytoplasm. And this is the reason why megakaryocytes look so variable in the biopsy. You've rightly pointed out that we can use stains to identify megakaryocytes. The most commonly used ones are CD61 and CD42B, and they identify all stages of megakaryocytes, including you can see very, very small forms. These are micromegakaryocytes or megakaryocytes. And of course, it picks up platelets as well. And you can see that this is a sinusoid and you've got lots of platelets around it. Another very peculiar thing that megakaryocytes do is called emperipolesis. And you probably heard of this from a disease called Rosai-Dorfman, where the cytoplasm of, say, macrophages contains lymphocytes. So you can see all sorts of hemopoietic cells within the cytoplasm of megakaryocytes. And this is called megakaryocyte emperipolesis. You remember what I said about megakaryocytes moving towards sinusoids, right? As they move, they have to go through a host of other hemopoietic cells which are in their way. So rather than pushing them away, what the megakaryocyte does is it starts forming tunnels within its cytoplasm and pushes its cytoplasm around these cells so as not to disturb them or destroy them. And that's why you get that effect of cells within megakaryocyte cytoplasm. And you will commonly see this in patients who've had viral infections before they've had their biopsies. So it's a reactive condition and nothing to worry about. Okay, moving on to another cell lineage, monocytes and dendritic macrophages. There are two main kinds of macrophage types within the bone marrow. One is your monocyte, which is a small round cell, which you're very, very familiar with from peripheral blood evaluation. And that's well seen in the picture on the left-hand side. So you can see these medium-sized mononuclear cells with very granulated cytoplasm. Okay. And then you've got much larger forms, which are your fixed macrophages in the marrow. They're much, much bigger. And their peculiarity is that they've got these dendritic extensions of cytoplasm, which go in between the other hemopoietic cells. And this comes out very, very well if you're going to do immunohistochemistry for CD68, which is a generic macrophage marker. And this picks them up very, very well. The thing to remember is the dendritic macrophages are fixed. They remain within the bone marrow. Their function is to mop up all the debris and also act as structural elements, keeping hemopoiesis where it is. The monocytes, on the other hand, are migratory. So they go from bone marrow into blood and circulate. Another type of macrophage or macrophage lineage cell is the plasmacyte or dendritic cell, which is responsible for producing interferon, gets activated in viral important function of macrophages within the bone marrow is to store iron. And this iron, as we know, is utilized for erythropoiesis so that we can get RBCs which contain hemoglobin. And the two right-hand pictures, the top one is the pearl stain. You can see the nice pinky orange background and you can see the blue colored granules of iron. And then the bottom one is the Giemsa stain, where you can see that you've got a very, very nice olive green color for the iron granules. The picture on the left-hand side shows you a very, very good example of macrophages mopping up debris within the bone marrow. So whenever you get a lot of marrow turnover, say following an infection or in a myelodysplastic syndrome, these macrophages become very, very prominent and they contain a lot of cytoplasmic debris. Moving on, plasma cells. They account for about 2% of all bone marrow cells. And the characteristic feature within the bone marrow is that they are by and large located around capillaries. So you can see the right picture. You've got this linear capillary and it's surrounded by a layer of plasma cells on both sides. Very nicely seen on the Giemsa stain on the left-hand side. So you see perinuclear box. This is where plasma cells are located in the normal human bone marrow. If you wanted to identify them selectively, you could use various stains. I would use MUM1 as a generic stain for plasma cells. And of course, we would use light chain staining to identify the different types of plasma cells. So kappa and lambda, and that's a picture of kappa lambda-ish using double color-ish. So the brown color plasma cells are your kappa stained plasma cells. They're predominant. And the red colored ones are lambda stained plasma cells. So the kappa lambda ratio is usually 3:1 in the bone marrow. The bone marrow also contains a lot of lymphocytes, usually 15% of total nucleated count. And most of the T cells, as you can see from the top two pictures, you've got about 4 T cells for every B cell. And the CD4-CD8 ratio within the bone marrow is in favor of CD8 positive cells. So you've got far more CD8 positive lymphocytes within the bone marrow than helper T cells. Bone marrow also contains NK cells, which you can identify using 56 or CD57 staining. They form a very, very small proportion. And I'm often asked this question about how can we differentiate between a normal plasma cell, which is 56 positive, and a normal NK cell. And the answer is that the NK cell, by and large, has a very, very corrugated outline to its cytoplasm, while the plasma cell cytoplasm is very, very smooth and